My name is Jacqui Curley and I work in the Healthcare Pricing Office, and it's great to see everyone again here. And thanks to all the HPO team on the organising side, and we have our HIPE desk outside there if anybody wants to talk about HIPE coding or learn a little bit more. So I just want to give you an update on some areas that have been happening around HIPE and some of the things that we're working on at the moment. Some of them we mentioned already this morning, but just to go through them a little bit. Okay, so I just wanted to start off by saying that we moved over to the 12th edition of ICD 10 AM, ACHI and ACS for coding from the 1st of January 2024. It was a huge effort, and a huge effort from the hospitals in their coding teams and the training, getting used to the new systems, and also the HPO in organising and delivering all of that and all the resources around it. So we had over 300 coders trained, and we actually held 8 specific update courses. And I really want to thank our colleagues out in the system who facilitated those courses, because we held some of them regionally, so it was great because the coders were able to travel to their regional course. We really appreciated that, and it made a difference to us, so thank you to those hospitals that facilitated that. And I think they provided the lunch and the tea and coffee. Stephen, I hope that's okay, but it really did make a difference, and we appreciated it. So we had some changes that just kept the classification up to date, which was great. So new procedures or diagnoses and things like that, but also around the guidance and the guidelines, there were some changes. So coders are really getting into that now and starting to bed down 12th edition. So we have a lot of clarity and tightness around additional diagnosis coding, which may come through in the data as we go through 2024. It's a lot stricter about when a condition can be captured as an additional diagnosis. We also had some new codes around COVID-19. And we also made the decision in consultation with stakeholders, including the National Cancer Control Programme, that we would retain our 10th edition approach to the coding of pharmacotherapy for neoplasms and neoplasm-related conditions. We just felt it gave a better picture of hospitals' activity in that area in terms of the data that will be available afterwards through the HIPE system. So, for example, we will still have the neoplasm code, which if we had have adopted the 12th edition change, we would have lost that. So that was a decision which has helped us keep our data, the trends of the data across the years intact. And that 12th edition training continues now. We are developing frequently asked questions documents, this COVID-19 documents, the Irish coding standards, all the data quality tools. So it's really bedding down that 12th edition. I'm going to have a slide on coverage in a moment, but just for those of you, because this is my opportunity to talk to management that I wouldn't normally get an opportunity to talk to, but just to stay in contact with your HIPE departments around their coverage, because they are dealing with that, having closed off 2023 at the end of the end of March, and now moving into 2024 data, that there are nuances and changes in that the HIPE process that may affect the timelines on it. And we are starting our data quality reviews and our HPO audits, our chart-based audits on 12th edition activity. So Helen and Orla and Margaret are out on the road now doing audits, and Marie and Aisling and Karen and Anna and Amy are reviewing the data and providing the training to coincide with those areas where coders might need additional information. Okay. So this is another area that we're working on at the moment, and with the development of the new HPO website, we are looking to develop some resources to help inform induction and training of clinicians and those interested in HIPE, or where HIPE managers might have to provide training at induction days, so that there's a resource pack available. Now, hospitals can obviously use their own training that they have for those induction days, but we just wanted to put something together that would give some resources and assist with resources for that training, or if you're providing information to clinicians on what HIPE is or the importance of documentation, clarity of documentation. So we have a document already on that, and we actually have some copies of it out on the HIPE desk outside. That will be up on the website. We have had this document already, and we have a HSE land training video already up on the system. But really what we want to do is bring this, put a bit more resources into it and put a bit more effort into it to make it available to you and to clinicians as we come in contact with them. And I would again urge those of you in hospital management around facilitating communication between your HIPE teams, your HIPE managers and your clinicians, your clinical directors. Really, that joining up is really important in terms of the quality of your HIPE data and the understanding that your clinical teams have of how the hospital is seen by agencies, stakeholders, policymakers. It's based on that activity data. So that's important. Okay. Now, this is an area, Mark kind of touched on this earlier, but I just want to talk about this around the probity and integrity of your HIPE data that's coming in from the hospitals. So we have national guidelines, very clear. Coders coming into the system from day one are instructed on these guidelines around what HIPE does and does not collect. It's a standardization of systems, and that's why we have definitions and guidelines in a system like HIPE. So HIPE does not include OPD, it does not include clinics, it does not include ED or patients who are partially admitted but staying in ED. It does not include step down, residential, elective admissions or readmissions to MAUs. So that's some of the areas. There's a longer list than that. But they're very clearly documented, and they are very clearly set out for those who collect HIPE data. So I'm bringing these to you as managers and finance managers, that HIPE does not collect those areas of activity. So we have recently sent correspondence out to some hospitals around areas where we have concerns on, particularly around some of the virtual EDs, where we have a concern or there's a potential issue and it needs to be resolved. Some hospitals it's a very, very small number of cases. Some hospitals it's a larger number of cases. But your data is being scrutinised, it's been analysed, it's been processed, and it's been processed beyond the HPO. It's all the policyholders and stakeholders are reviewing the data. So if we tell the system that HIPE does not include ED or OPD data, we are reflecting that on behalf of you as those who are submitting that data. So I have up there one of the recent reports from the Road Safety Authority. Actually, I think they're working on the report now. It was presented at their conference, where the number of accidents reported by the guards was different to the number of accidents reported on the HIPE data for admitted inpatients. So this is just to explain to you the importance of having integrity and probity in your patients. So only admitted inpatients and day cases come through the HIPE system. So we will be following up on those areas with hospitals because we are dealing with historical ward registrations. We know that. We know there's things going back years that nowadays, if that ward registration was to come into HIPE, it probably may not be accepted. So the other thing to mention about that is that clinical coders work to a clinical coding practice framework, which is an ethical approach for coding. And it instructs coders not to, I wrote it down there, I have it on my slide, on my notes here, that those involved in coding must not submit to pressure or apply pressure to manipulate coded data for any purpose that misrepresents the patient's episode of care. And what we're doing is all about the patients and accurately reflecting what happens for the patients in the hospitals. So we will continue to review those wards and communicate with hospitals where we have a concern. We're very happy to look into things and see what's happening on the ground. And visiting those wards will probably become part of our audits as well as we're out in the hospitals on site. So I just want that to be considered, particularly as I have this audience for a couple of minutes today. I really wanted to make that point about requesting HIPE departments to code activity that is not valid HIPE activity. Okay. And this ties into it as well, because some hospitals struggle with coverage through staffing or issues that arise during the year. But I would just like to thank all of those involved. The coverage for 2023, and we had challenges again in 2023 around work to rules, recruitments, and also that updated 12th edition. But we made it. We got 99% coverage for 2023 data, so thank you very much. So that file is locked now at national level, and that will go on now to be used as a national view of acute hospital activity for 2023. Okay, so that's data's crucial, critical data in terms of planning and managing the health service. So the coverage, as Stephen and Mark and Brian, everybody has mentioned it so far this morning, the coverage is really important. So we monitor coverage on a monthly basis. We have an escalation process in place where we report into, it's the acute hospitals division at the moment, and it goes into the monthly performance meetings from there. And we also escalate it up to hospital management as well, because it's beyond the HIPE department when there's a coverage issue. So the staffing and resourcing, as well as the quality of data, does matter for your hospital. And also, particularly as we move into those new health regions now, things are going to be looked at in a different, a slightly different lens now with the health regions. So I just put up the numbers there. So I think we had an increase of about 7% in the activity up to 2023, from 2022 to 2023. So that's our largest ever HIPE file, 1.88 million discharges. It's a vast amount of data. So it's a huge credit to the people here. I just wanted to mention this piece of work as well. This is work that we do in the HPO that you may not be aware of. And it's one of the demands on our resources for our small team in the HPO. So our work with the cross-border team in the HSE, and I think some of our colleagues are here today. So the HPO assists the cross-border team in ARDRG assignment for patients that go to the EU or to Northern Ireland for treatment. I'm sure you've heard about it, people travelling for treatment. So those patients are funded as to what they would be funded if they had that same treatment here in Ireland. So it's based on the DRG assignment. And it was a recommendation from a recent Ombudsman's report for the HPO to be involved in the appeals process and to review those appeals cases and the DRG assignment. So it's a significant area of work for us in the HPO, and it's really a public service that we're providing because people are waiting on this DRG assignment to know how much funding they're going to get for their travel, for their service. So we get the initial appeals in to assign a DRG to code and assign a DRG, and then we also get the appeals in which are required coding and DRG assignment as well. And we have to balance that timely response for those patients with our HPO service delivery as well. So just to give you an idea, some of the numbers. So in 2023, we had 567 of the initial DRG assignment ones, and we had 2022 appeals. So we only started them from June onwards. And then in 2024, we've had 315 applications for the initial DRG assignment, and we're up to 48 on the appeals. So it is a significant area of work, and we just have to balance that with our own service delivery as well, because it's relying on those, as I'm sure you all know here, those niche coding classification skills with the team here. Okay. I just wanted to do a little bit about COVID-19 because we are kind of coming to the end of that whole broad impact of COVID-19 and just a little bit of a look back on it. So HIPE data has provided a huge volume of information around COVID-19 and patients in public hospitals. And it's really been valuable in managing service delivery and planning right from the initial days, right back. We got our first codes in February 2020 for COVID-19. So the whole way through, we've been evolving and developing the HIPE data around COVID-19. So it's a system-wide effort. The hospitals played an absolute blinder in COVID-19 HIPE data collection. The requirement to code them within 48 hours, it was just huge. And the support of their hospital colleagues, the clinical programs, we had great support with clinicians helping us with queries and things like that. So the wider HSE as well was fantastic. But that means that this data is available now, and it's a very important data set, and will continue to be as we go on through kind of, I suppose, the fallout from COVID-19. So that data is available for research. There's a COVID-19 data hub, and we've over almost 84,000 COVID-19 discharges on HIPE from 2020 to 2023. And I just put up some of the summary data from that just to show you. So this is for all the years 2020 up to 2023. And this is thanks to data analytics colleagues Lorna, her dashboard for this. I just wanted to give you a little snapshot now as we're kind of coming out the other end of it. But almost 84,000 discharges. The split between male and female is almost, 49%, 49.6 and 50.6, 50.4%. And the amount of the volume of bed days there, over 1.5 million bed days for those patients over the 4 years. And the ITU days were 6% of those bed days. So it was huge amount of activity in our hospitals. And on this slide, this is just a little snapshot now that I took off that dashboard, but on this slide you can see this is across all the years, so it starts off in 2020, but you can see the peaks and the troughs as we went through vaccinations and lockdowns and that. But it's interesting in the table there on that slide that the volume of discharges in 2022 on HIPE was over 35,000. It's a huge amount of discharges on HIPE for 2022. So while the acuity may not have been as much, but the volume of discharges was huge. And in 2023, over almost 19,000 discharges. And just to say as well that I know even now, as we speak today, there's a HIPE department that has a number of staff out with COVID-19. So we're still having those kind of impacts as well on the delivery of the HIPE data. Okay, so I just want to mention a couple of things finally. Just to mention that our linking in with the clinical programs has been really beneficial. So we link in with a lot of the clinical programs within the HSE and also with the clinical audits in NOCA, the National Office of Clinical Audit. And it really gives us access where there's clinical issues that arise that we need input on. We can't answer them from a pure HIPE classification point of view. So one of the areas that we've had ongoing collaboration is in the area of anaesthetics, and we link in with the National Clinical Programme for Anaesthesiology, and the 10th report was published just before Christmas, and our colleagues from the anaesthetics programme are here today, so thanks to them for their support, because it really is great and it gives us confidence then when we're speaking to clinical programmes that we can link in with them and we can use this as a great example. We're linked in with the sepsis programme and they're conducting another audit now as well. On 2024 data, they're putting together the parameters for their national audit, and that's through the sepsis programme. So that's an audit through that programme, through the assistant directors of nursing in that programme. So it's just fantastic. The hospital-acquired complications dashboard. So that was a project that we were working on, and we brought that through fruition, and many of the hospitals here were involved in that in some level. So again, thanks to you so much, because there was a lot of reviewing of dashboards and data for that. So we did create the dashboard, and we have just recently repopulated it with 2023 data. So we're going to take another look at that and see can we advance it on. And there was interest from the sepsis clinical programme again in using that dashboard around hospital-acquired complications as a resource for them. So we'll continue on with that. Huge support from hospitals, HIPE staff and teams across the wider HSE on HIPE matters. And I think it's building all the time, and I can see it all the time. The people who are in contact with us and the people who are trying to develop things locally, and that's what we want to help resource and provide resources for and support you in that work. But really it's trying to keep HIPE developing and keep HIPE as a responsive system, as it always has been. But it's only with your input and with your support and with your engagement that we can do that. And we're very appreciative of those who do bring those projects on and work on those projects with us in collaboration. So I just want to say thank you to everyone involved in organising today, my HPO colleagues and our HIPE community. As always, thank you very much. Thank you.